Welcome to CME on ReachMD. This episode is part of our Minute CE curriculum. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
This is CME on ReachMD, and I'm Dr. Karin Blakemore. I'm here with Dr. Emilie Vander. Dr. Vander, in continuing our discussion, could you explain the utility of employing what we know about the FcRn pathway in the placenta to treat fetal disorders that may be affected by this physiologic pathway?
We actually have really exciting data from a recently published phase 2 clinical trial that was just published in the New England Journal of Medicine in this year, 2024, looking at the use of a specific FcRn inhibitor, Nipocalimab, in preventing fetal anemia in HDFN. Just to give you some background, Nipocalimab is a human anti-FcRn glycosylated IgG1 monoclonal antibody engineered to bind to and blockade FcRn with high affinity. This monoclonal antibody, in theory, should be able to block and reduce the risk of morbidities associated with transplacental passage of pathogenic maternal alloantibodies, like those in FNAIT or HDFN, especially to the fetus. In July of 2019, the FDA actually designated Nipocalimab for the fast track approval process for HDFN, and this was again done in March 2024. The same designation was granted for its use in FNAIT as well. This study, the New England Journal of Medicine phase 2 study, was an international open-label single-group study. In the study, IV Nipocalimab was given to pregnant participants from 14 to 35 weeks gestation. In order to be a candidate for the study, women had to have pregnancies at high risk for recurrent early onset severe HDFN. The primary endpoint for the study was a live birth greater than or equal to 32 weeks gestation without intrauterine transfusion versus a historical benchmark. This phase 2 trial found that their primary outcome of live births greater than 32 weeks without transfusion occurred in 54% of the tested pregnancies, so 7 out of 13, with no cases of fetal high drops and no significant maternal or neonatal infections noted, which is one of the concerns about the use of an FcRn inhibitor. 6 infants or neonates received simple transfusions after delivery, and one of those also received an exchange transfusion. Thus, these findings demonstrate a proof of concept that FcRn inhibitors can decrease transplacental passage of antibodies, leading to decreased need for transfusions and even the highest risk of pregnancies. In theory, this could be extrapolated to FNAIT given the similarities between the two disorders, but more research is definitely needed to kind of further understand this process.
And I think it's interesting that the study that was published was looking at very severely affected red cell alloimmunizations. And the expectation would have been for far more transfusions than the few that ended up happening in that cohort.
Yeah, really promising data and exciting. And obviously lots more to come for FNAIT as well. I think also, when relative to FNAIT, where you guys are doing maybe one intrauterine, transfusion, in HDFN, they often end up needing multiple transfusions throughout the pregnancy. So this is definitely something that could prevent many of those transfusions or, go from 3 to 1 or something, which is still a significant improvement for HDFN in those really highest at-risk patients. I think the other promising finding from this study is the side effect profile for this medication seemed to be well tolerated. No significant adverse effects outside of kind of the usual pregnancy ones that they reported. And so unlike the kind of mainstay treatments for FNAIT currently, IVIG and or high dose prednisone.
Well, thanks. I think our time is up. And thanks for this discussion.
You have been listening to CME on ReachMD. This activity is provided by Omnia Education and is part of our Minute CE curriculum. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.